everybody, and it's with great pleasure that I welcome you to this lecture by Professor Lynne Stokes, who is visiting Australia from the UK at the moment. And I'd like to thank Amanda Baker, who's helped to facilitate this presentation as well. My name is Gaj Panagata from RMS ANZ. You would have probably read a little bit about Professor Lynne from the sheet, but just to recap, she's a rehab consultant, director of the Regional Hyperacute Rehabilitation Unit, which I think has just got the most terrific name and the most terrific logo. And I think we probably need to lift our game here in Australia to have more cool, interesting names and logos like that one. She's director of the UK Rehabilitations Outcome Collaborative and has done a lot of work with the Department of Health in UK over many years around commissioning in the rehabilitation landscape. And she's also worked with AROC here closer to home. So I'll hand it over to you, Lynne. And for all people listening and watching, you can drop questions into the chat as we go, and there will also be time at the end for questions. Thanks. Over to you, Lynne.
Thank you. Thank you very much indeed. Thank you for that. Yes, the logo is the flying pig because our motto is that pigs can and really do sometimes fly. So thank you very much for inviting me to give this talk. It's a great pleasure to come back to Australia. For those of you who don't know me, I started out my very first job was in Port Augusta as a flying doctor with Royal Flying Doctor Service, and I've been taking every opportunity ever since to come back to God's own country. I love the culture, I love the wine, and I particularly love the diving, but it's always a great pleasure to be here. So thank you very much for inviting me. So yes, back in the UK, I'm a consultant in rehab medicine for my daily work, and I direct the UK Rehabilitation Outcomes Collaborative, which is the equivalent of AROC. And we've been developing that in collaboration with AROC since 2006. We collect episode data for every single patient admitted for specialist rehabilitation in England. That's the level 1 and 2 services I'll talk about. We collect data on their needs for rehabilitation and their complexity, the inputs provided to meet those needs, and then the outcomes that result in terms of functional gain and cost efficiency. And the purpose of this is ultimately to demonstrate that rehabilitation provides value for money. So if we look at the development of international case mix in the last 30 years, health systems around the world have introduced activity-based costing and payment models. Case mix design is often based on diagnosis-related groups, but we know that these are really poor indicators of cost in rehabilitation. So in the 1990s, we saw development of payment models for rehabilitation, first of all in the United States, where uniform data systems developed function-related groups based on FIM scores. And then following that, about 10 years later, AROC developed a blended payment model, also based on the FIM. In terms of the value of rehabilitation, both systems use FIM scores on admission as a proxy for case mix complexity, and FIM scores on discharge as a proxy for the ongoing costs of care, so that FIM gain over length of stay is used as a measure of cost efficiency. So case mix development in the UK started another 10 years later, so we were able to learn from those models. And by this time, we realized that the FIM has its limitations because it doesn't directly capture care needs or the cost of care. So the UK case mix model has evolved really based on more direct measures of cost, both of rehabilitation and of cost efficiency. There are some key differences between Australia and the UK, but one of the most important ones is sheer size and population. So these are to scale illustrations just demonstrating the size of Australia compared to the UK, and also the fact that we have about 3 times the number of people in that small area. So we're small and densely populated, and that means people travel shorter distances. And that means that it makes sense to provide some services in regional networks. So we have services provided at local level, secondary level, and then in tertiary or regional care. And those are levels 1 for the tertiary care, level 2 for the secondary, and levels 3 for the local care. And this means that what happens is we cluster our low volume, high complex cases in regional centres, the level 1 centres, who therefore take only a selected group of the highly complex patients. So if we look at all the patients requiring rehabilitation and we look at the complexity of their needs, we see that the majority of patients would be in the level 3 services in their local non-specialist rehabilitation services, as we call them in England. A smaller number require a local specialist service, the district specialist service, and only a very small number require the services of a level 1 tertiary tertiary specialist service. So that means to say that we have this tiered system, which presents a challenge for us. The NHS provides health and social care, which is free at the point of delivery. And that includes lifelong nursing home care for profoundly disabled patients. So that has meant that the NHS has been prepared to invest up front in rehabilitation, including quite slow stream rehabilitation over longer periods of time, to gain benefits that will affect the long-term outcomes for that patient and the ongoing care costs. But we still have to make the argument that they provide value for money. So when we think about understanding case mix, complexity and cost, the first challenge is to understand the cost of rehabilitation for patients with different levels and different types of rehabilitation need. Now, most case mix models recognize that there's a range of case complexity and cost, but they assume that units have a broadly similar case mix, so it all evens out in the end. Now, that would be the case if everybody took this same mix of rehabilitation services, which is broadly what happens in Australia, because the large majority of patients are in this group, and all of those come into rehab services in Australia, whereas in the UK, they tend, specialist services are only these level 1 and 2 services. So if we were then to take an average cost across all of that group, we find that the level 3 services did very well, thank you very much, in terms of the income. The level 2 services would struggle, and we basically wouldn't be able to afford any level 1 services at all. So there's no one size fits all for this tiered system, and we needed more granularity to account for the different service profiles and individual complexity, which of course may vary over time. When we're talking about cost efficiency, it's important to understand perhaps the different terms. So cost effectiveness is a term we use, which really means achieving the desired outcome for the least amount of money. Whereas cost efficiency recognizes that you can save money by working in a different way, but you may need to spend more money to achieve a better outcome and thereby generate more savings. So it's cost efficiency that we've really focused on here. And in order to look at that, we need to know, first of all, how much rehabilitation costs, and then how much it saves by improving independence so that you reduce the costs of future ongoing care. Now, if we use FIM efficiency as a proxy for cost efficiency, we have to remember that the FIM is an ordinal scale, so it will inevitably produce data which is an S-shaped curve. So when we look at patients coming into acute care, and the FIM scores, they're likely to be down at the bottom of the scale, around about 18. As they go through rehabilitation, they'll hopefully improve up towards the top of the FIM and plateau out around about 126. But if we're going to look at that FIM gain over length of stay as the measure of cost efficiency, that's only going to work in that straight part of the scale. And if we have patients B, for example, who are in the upper part of the scale where there's a ceiling effect, or the bottom part of the scale where there's a floor effect, then the gain is going to be relatively less for the length of stay. And what we need at that point is other measures that measure above the ceiling of the FIM, which is where we add the additional FAM items, looking at cognitive and psychosocial function, and below the floor, which is where the Norfolk Park dependency scale comes in, because it quantifies the difference between, for example, the time taken and the number of people required to provide care, which the FIM doesn't. So our UK ROC system was founded in 2008. We initially started with an NIHR program grant in applied research, and we developed our national clinical database and registry, building on the AROC system, but adapting it for use in the UK and using other tools. And in order to do this, we worked with many people around the world, but in particular, an important group of people from Australia and New Zealand who really helped us kick this all off. Since 2015, At the end of that period, the UK database has been funded directly by NHS England to provide its commissioning data set. And as I said, we provide patient-level episode data for all specialist rehabilitation services in England. That's the level 1 and 2 services. There are about 75 of them. And we now have over 90,000 registered episodes. Since 2017, we achieved registry status, which meant that we could collect identifiable data. And in the UK, that means that we have a single NHS number that for every single patient, and that follows them wherever they go in whatever services. And so we can now collect and report that and use that for tracking patients, and therefore for linking with other data sets so we can follow people down their pathway of care. As we know, the FIM is widely used as a universal outcome measure for rehabilitation, but as we just looked at, it has known floor and ceiling effects, and therefore it provides limited assessment of psychosocial function, which is often the main limiting factor for outcome in severe brain injury, which is why it doesn't necessarily perform very well in those complex end cases. So the functional assessment measure, the FAM, was developed by Carol Hall and colleagues in Santa Clara Valley Medical Center back in the 1990s. It doesn't stand alone, it adds 12 items to the FIM, mainly addressing psychosocial function, so we now have a 30-item scale. It was originally designed for traumatic brain injury, but it's applicable in other conditions, and the UK version now includes an extended activities module, including workability, and we use the UK FIM plus FAM as our primary outcome measure in UK ROC. And I'm just going to focus for a moment on the FAM splats. I think most of you will probably be familiar with this, but just in case not, these are radar charts where each of the items of the FAM, 30 items, are arranged as spokes of the scale. And then we have a score from 1, totally dependent, to 7, fully independent. And we can look at the scores on admission in the yellow and the scores on discharge and see the change that's occurred during an admission in the blue. And we can measure that on an individual patient basis, or as here, we can look at the median scores for the different levels of service. So here's the median scores for the level 1 services compared with the median scores for the level 2 services. And you can immediately see, therefore, that there's a big difference in the level of ability of patients coming in on admission. Most of them are making changes around the whole of the FEM, less so here for the level 1 services. So just to orientate you, we have self-care, bladder, bowels, locomotion, communication, psychosocial and cognitive items. So you can see that many of the patients in the level 1 services are going to remain dependent for mobility and possibly incontinent. They'll make some gains in terms of self-care, particularly eating and swallowing, but they make significant cognitive and psychosocial gains and communication gains, which is why the FAM items are so important for us, perhaps slightly less so in the level 2 services, but nevertheless, they add that extra information. But equally, the level 1 services are not all the same. We have the level 1A services, which are for profound physical disability. That will include patients with prolonged disorders of consciousness. We have the level 1C services, which are largely cognitive, behavioral, people who are walking wounded, and we have level 1B services, which are a bit of a mixture of the two. So here are the median FAM splats for the level 1A, physical dependency services, level 1C, the cognitive behavioral group, and the level 1B, which is a mixture. And we can see that those are very different profiles. And by producing these FAM splats, we help commissioners to understand that it is by no means the case that services all look alike. They have very different profiles, very different caseloads, and very different expectations for outcome. So our UK ROC extended data set looks at complexity of needs for rehabilitation in terms of the rehab complexity scale. The inputs provided to meet those needs are measured by the Norfolk Park nursing dependency scales, the outcomes by the FIM plus FAM, and as I've said, we also look at reduction in care needs and care costs. Our episode costs are based on complexity weighted bed day cost, and our cost efficiency is the time taken to offset the cost of rehabilitation by savings in the cost of ongoing care needs in the community. But if we're going to embed measurement into clinical practice, we require very simple, practical tools that are useful to clinicians. So our first priority was to be able to look at rehabilitation needs for costs. Now, the principal determinants of cost in rehabilitation are, first of all, the basic care and nursing needs that somebody will need wherever they're being cared for. Therapy needs, a number of disciplines, the intensity of input, and any specialist facilities or equipment. The medical environment, do they need to have 24-hour emergency care available? Do they need special procedures or investigations? And finally, the bed days, the amount of time they spend. And if you know all that about a patient, then you know a lot about the costs of their rehabilitation. So the rehabilitation complexity scale was designed to reflect exactly those items. And you can see that it's scored here. It's very simple and quick to score. We record it serially over time, and it can capture changing needs as the patient progresses through the program. So in my unit, we record it every Tuesday morning. It's part of my ward round. It takes me 5 minutes to record the RCS scores for all of my 24 patients. And that gives me a very good idea of the complexity profile of my ward before I go into the rehab admission planning meeting and working out who I can bring in and how many dependent patients I can have. But looking at our weighted bed day payment model, if we look at the serial rehab complexity scores over time, then the care, nursing and medical needs in blue here tend to go down over time if somebody's on a restorative rehabilitation program. The therapy needs, if anything, increase as they perhaps sort of get to grips with patients, get them up on their feet, and then they stay more or less the same. The therapists may be doing different things. They may be getting the patient out of bed, into a wheelchair, onto their feet, and then a flurry of activity post coming up to discharge. But more or less, it's the same amount of intensity, just different things. So if we look at the total scores, which the same patient are here throughout their admission, our complexity weighted bed day model is based on 5 tiers of the total rehab complexity score. And so you can see that initially they're fairly high cost, and the payment goes down over time as they become more independent and therefore cost less to manage. And this is our mandated currency for specialist rehabilitation in England. So our daily tariff falls as complexity reduces, which is fair to the purchaser and to the provider. And it also provides an incentive to move the patient on to the next stage of care. And that's slightly different from the Australian system, where complexity is largely based on the admission FIM and then stays the same through the admission. But the challenge we have for very severe disability is that many patients will remain dependent and not change very much on the FIM, but reduction in care costs is still important. So if we take, for example, a patient with a severe brain injury, admitted for a 4-month program, a specialist rehabilitation, if they didn't come into rehabilitation, but instead went home into the community before that, they might require a care package involving 2 living carers. These costs are just model costs, they're out of date, but it might be that they require 2 living carers, say at a cost of £2,500 a week. If after rehabilitation that's reduced to 1 living carer, it's half the cost, so we're saving £1,250 a week. If the cost of treatment was £65,000, that's quite expensive for a period of rehabilitation, but by that weekly saving in care costs would offset the cost of rehabilitation in 12 months. And that's a really powerful argument for providing rehabilitation. But we needed the measures to record this, not only just as part of a health economic rehabilitation research project, but actually collected routinely in the course of clinical practice for every patient going through rehabilitation. So the Northwood Park Dependency Score provides us with a direct assessment of care needs in terms of the number of carers to help with each task and the time taken to complete it. It then translates by a computerized algorithm into outputs that include a timetable of care needs in the community, the care package to meet those needs, and its approximate weekly cost. So as I've said, the cost efficiency is the time taken to offset the cost of rehabilitation by savings in the cost of ongoing care. But we can also compute that across their lifetime by looking at the annual saving in care costs and multiplying that by their remaining years of life, allowing for the fact that patients with severe disability will have a reduced life expectancy, but nevertheless, we can compute those lifetime savings. And that's now built into the UK ROC software for every patient as they're going through. So just looking at some of the data we've published, the first publication was in 2016. It was about a 5-year extract of data, included brain injury, spinal cord injury, progressive conditions, all of those with complete data on the Northwood Park Dependency Score and the FIM plus FAM. There were just over 5,000 patients. What we can see is it really doesn't matter what your underlying diagnosis is. Broadly speaking, we've got the same information. Length of stay in the UK is about 90 days, about 3 months. Cost of rehabilitation programme at that time, about £40,000. Reduction in care costs, about £500 a week. And the time to offset the cost of rehabilitation, therefore, about 18 months. And as I say, there was some variation across the different conditions, but largely it was a similar message. We also divided patients into a high, medium, and low dependency group. So a high dependency group is patients with a mission MPDS score of over 25, meaning that they required 2 carers for most care tasks. Medium dependency, they required 1 carer, and for low dependency, they were basically had a dependency score of under 10, were moving on towards being self-caring and on their feet. So if we look at the comparative length of stay between the low dependency and the high dependency group, we can see that the high dependency group stayed twice as long, roughly. They therefore cost about twice as much to rehabilitate. But if we look at the mean reduction in care costs, there was about a 6-fold difference, which meant that the time to offset the cost of rehabilitation was actually shortest in that high dependency group compared with the medium and low dependency group. Whereas if you look at the film efficiency, because of that S-shaped curve, it will nearly always show that the medium term dependency group is the most efficient to treat. So this was important because basically it meant that severely dependent patients who were unlikely to receive rehabilitation in some of those countries that require patients to show a change in PIM scores in order to continue rehabilitation, we were able to show that actually for those patients, changes in care needs that fell below the floor of the PIM nevertheless meant this was a very cost-effective group to treat. And so we needed to make provision for those patients as well. So we look at lifetime savings, which we did now in a traumatic brain injury group. We published this in 2019. By this time, we had about 6,000 patients with traumatic brain injury who've been admitted to the level 1 and 2 units over about 8 years. And again, we've got a broadly similar finding. So the mean age was 49, mean length of stay around about 90 days, cost of program around about £40,000, reduction in care cost around about £500 a week, which meant that the annual savings was £28,000 per week. The life expectancy, accounting for the fact that some of these patients were severely disabled and therefore had a shortened life expectancy, and we used the US Life Expectancy Project data for that. So we found that the life expectancy of remaining years from that mean age of 49 was 21.6. So on average, they were living up to around 70 years. That is a reduction, 72 years, that's about a reduction of about 10 years. But it meant that the net total lifetime savings, having paid for the rehabilitation, was about £250,000 on average per patient, which meant that for that 6,000 population, the overall saving was £4.1 billion. And that meant that rehabilitation was one of the most cost-efficient interventions in healthcare. And that was an important argument that enabled us to argue for services and has been pivotal to gaining some expansion of services in England. We've looked at various other publications. I won't go through them all, but we've looked at spinal cord injury, multiple sclerosis, prolonged disorders of consciousness, and different models of healthcare and hyperacute rehabilitation. Here in Australia, we've also explored these models to see whether they work, particularly for patients with that more complex end of catastrophic brain injury. So over in Melbourne, Tash Lannin started up a new statewide rehabilitation unit for acquired brain injury in 2016. And as part of a research evaluation project, which was the Outcome ABI project, she used tools from the UK ROC dataset from the start to look at the outcomes, bearing in mind that we knew that this group was likely to be in the more complex brain injury group. And we adapted the NPDS MPCA costing algorithm for Australia using the NDIS costing. And then over in Perth, the Brightwater Care Group has also been using the tools for many years now. We've published data on outcomes from specialist community slow stream residential rehab that showed continued gains even after 2 years post-injury. So if you look briefly at the data from the ABI project, it was an observational cohort analysis, 2 years of data, 196 patients. And I've just put the comparative data here between the Australian mean and the UK mean that I presented in the 2016 publication. So we've got roughly similar age, length of stay slightly shorter in Australia, but the cost of the program considerably more, even allowing for the pounds to dollars exchange rate, because care and rehabilitation is more expensive in Australia, but so is the care costs. So in point of fact, the care costs and weekly reduction in care costs was significantly higher than in the UK. and therefore the overall annual savings. The life expectancy, this was a slightly younger group, therefore slightly longer life expectancy, but the net total lifetime savings were 3.4 million pounds. And basically, the bottom line outcome of that was that for every dollar spent on rehabilitation, we saved $91 in the cost of care ongoing in the community. And so that, again, is a useful strap line to have. Analysis by dependency, we also looked at that, same division of high, medium and low patients. And you can see that the length of stay was about 4 times as long for the high compared to the low dependency patients. So the cost of the rehabilitation was over sort of 3 to 4 times higher. But the mean reduction in care costs also greatest in this group, so that the time to offset the cost of rehabilitation broadly similar across those dependency groups. And FIM efficiency, if anything, was greatest in the low dependency group. So the thing that stands out here is the cost of care is comparatively higher in Australia, and that is actually true. Although having said that, it's true that the UK figures were based on our original costs, which we kept the same throughout our publications for comparability. And now they're 20 or 30 years, so they underestimate the UK costs. So that's caused us to revise the costs, and we're just publishing updated data with updated costs. But even so, there are some differences between us and Australia, but the broad take-home message is the same. The time to offset costs of rehabilitation was shorter across all dependency groups in Australia because of those care costs, but this was also a rapid access unit, so they were taking people relatively early. So the mean time since onset was 64 days compared with the mean in our UK cohort of really 10 times that. And even if you look at the median, it was about twice as short. So this was emphasizing also the importance of bringing people into rehabilitation earlier. So obviously, some of this is natural recovery going on, but nevertheless, you're catching them before they accrue long-term problems such as contractures that take time to undo. These are the FAM splats for the ABI group in Australia, and again, you can see those big changes all across from the low, medium, and high dependency group. And you can just see for that the group of people who came in what I call a polo FEM with one around the clock, those big changes that they could make. We also looked at follow-up up to 2 years, and the green is shown there, and you can see that they did continue to make gains after discharge. Up to 2 years. And that's important because if the assumptions in our overall model are that people maintain those gains after they leave rehabilitation, we need some evidence to show that that is the case. And this provides evidence they not only maintain the gains, they actually build on them. So if anything, our cost efficiency model is underestimating the cost benefits. So going forward, yes, there are some differences in health culture between UK and Australia, but we face the same challenges. And there are opportunities for closer collaboration going forward. We've now got proof of principle for the UK model of cost efficiency in Australia. So we're working with AROC on wider application for complex rehabilitation, looking at a project examining its application in New South Wales, Queensland, and South Australia. And we're also looking at the added value of the FAM items for relevant patients to capture that cognitive and psychosocial function. There are obviously some barriers to overcome, and the challenge in particular is one of additional data collection and the time that takes. So we need to engage clinicians by making it meaningful for them. We need simple tools that are timely to collect and provide clear added value for day-to-day clinical decision making. So just coming back to the NPDS, it's designed to be intuitive to use. It doesn't require specific training or accreditation. It takes 3 to 5 minutes to complete by a nurse or carer who's familiar with the patient. In my unit, we collected on all patients every 2 weeks because it helps us to understand the dependency profile of the ward. And the nursing team want that information to balance their load of work and decide who we can manage to bring in. And they can also use it to support requests for extra staff when the ward is heavy. But we also have the added value of the MPCNA algorithm, which we get from a touch of a button using the software. And so I'm just going to explain this a little bit in the last bit of the talk. So what it does is it produces a timetable of care needs when those needs happen, which can assist with discharge planning, and also prediction of the impact from small changes in a patient's dependency. So our timetable of care needs looks like this. It's generated by the software and it's based on some validated assumptions. So for example, if you need help for eating, for example, that means to say you'll need some help in the morning, the midday, the evening when you have your 3 meals a day. If you need help dressing, you'll need help in the morning when you get dressed and the evening when you get undressed. And we've put times to what those different levels mean. So it builds this timetable in 6 slots: morning, mid-morning, midday, mid-afternoon, evening, bedtime, and nighttime. We get a calculation of the total care hours and the restricted care hours that allows some overlap within those hours. And then what we know is if you're needing care in more than 4 of the time slots during the day, you're quite likely to need constant care throughout that day. This is our dependency score, and I'm just going to show you a very quick example of how this works in practice. So we've got Mr. X, he's got brain and spinal cord injury, he's mobile in a wheelchair, he transfers independently, he needs a little bit of help for washing and dressing, but he's also a bit impulsive because of his brain injury, he needs prompting and he needs hourly checks. So if we look at his dependency score, we can find that he's pretty much independent, he's continent, he needs some help for washing and dressing, and he needs help to maintain safety. He can't be left safely for 2 hours. So the goal was to improve his safety awareness to allow him to be able to be left alone for more than 2 hours, so between, say, breakfast and lunch, which would allow him to be able to go home and be managed at home. So that was his goal. So here's his part dependency score as it's currently scored, and as I've said, here's his score here. He's got a total score of 14. But when we've got that score here that he can't be left for up to 2 hours, then we've got that need for a safety check at each of those 6 time points. So that means to say that he needs someone with him all the time. But apart from that, he only really needs help at the beginning and the end of the day. So if we look at the care needs assessment, when that translates out, it translates out into an estimate of the weekly care hours, but particularly it translates into the need for a live-in carer with 4 care hours cover a day at the cost of around about £4,000 per week. Now, when he got to the end of his rehabilitation, we hoped that he would be able to be left for more than 2 hours, and that would mean, if we put in the 1 there, it gives us our prediction out of what his safety awareness will be, and now that's gone down to just 3 safety awareness checks per day, and that means to say that his care package has gone down to a cost of £747 per week. So just by the change of that 1 item, which is given, so one item change in the dependency score, we've got a big change in care costs, and that helps us to argue for bringing in this person. So we can do that. We did bring him in. We got him independent. Actually, he was safe to be left all day, so he actually exceeded our expectations. So we did well on that. We were able to show the resulting impact of change. So in summary, Norfolk Park Dependency and Care Needs Assessment, simple and quick to apply, can be used in clinical practice to inform both care planning and to quantify care costs. It's a generic tool. It's not necessarily reflective of individual circumstances, but it can be used to predict care needs and costs on a comparative basis, regardless of what a person actually gets, but in terms of what they would get based on those assumptions which have been checked and validated over the 25 years or so for which we've now had the scale in place. So this cost efficiency model can be used to demonstrate that rehabilitation provides value for money. It has demonstrated applicability in Australia, and it's now ready to roll out on a national basis. And that's really part of the purpose of this, to really explore how we might be able to do that collaboratively. So I just want to acknowledge, first of all, the funding for the work that's happened, but more importantly, all of the patients, the NHS research staff who've helped us to put that into actual practice, members of the AROC team and all of our other collaborators around the world. So we're open to questions and discussion.
Perfect, thanks, Lynne. Yep. Okay. So we had that. Shall we go to that written in question first, Lynne? That someone wrote it about. So this was regarding I'll just read it. I'll just read it out. It's probably easiest. So I understand that BSRM recommends one rehab physician for a population of 250,000 in the UK. I also see that majority of strokes in the UK are under stroke physicians, with rehab physicians taking a few complex cases only. And this is different here, where most of the stroke patients requiring inpatient rehab go under rehab medicine quite early, usually within 1 to 2 weeks. So do you recommend a high number of rehab physicians, say 3 per 500,000, because of this difference? Not an easy question, Lynne, but what do you think?
Yeah, so that's why I just flipped back to this slide, if you can all still see that. So the difference between what we call specialist rehabilitation in the UK and what you call it in Australia is that we're only dealing with this group of level 1 and 2 services, where we have the rehab medicine physicians. And the definition of a level 1 or 2 service is that it has always led by a rehab physician. These other level 3 services are led by others, so they'd be care of the elderly, stroke physicians, and so on. That means to say they're specialists in other areas, not necessarily rehabilitation. It's not that they don't have any specialist input, but they're not specialist rehabilitation as such. They have a much quicker throughput, and they have relatively lower level needs. So obviously, if you're covering all of that, as you do in Australia, you need a much larger number of rehab physicians. The other thing in the UK is that we have quite a big restriction on how many rehab physicians we can train, and we have to get numbers approved for those, and unless you have a training number, you can't train as a rehab physician, and it's been extremely difficult to expand specialties because of that, because the GMC, the General Medical Council, keeps a very tight control of that. So we're limited by literally our definition of specialist services, and that's why we have the relatively small number. Having said that, those standards were 2010, and they're pretty old now, and the complexity of caseload has gone up, I think, for all of us all the way around the world. I hear the same in Australia, that the complexity is rising. So the idea that you'd have one rehab physician essentially for a catchment area of 250,000 is really not doable now, because even the specialist level 2 services require at least 1.5 or possibly 2 rehab physicians to make sure that they're covered. So A, those figures are out of date, but B, they don't apply to Australia, where you have the rehab physicians in this much larger group, and of course you should have, and we'd love to have them too. So basically speaking, yes, of course you need more rehab physicians than we've got, and our model doesn't really apply in the same way as it does in Australia.
Thanks, Lynne. And I've got a question for you. You spoke about that process that's sort of baked into your ward round, essentially looking at resource utilisation.
Yeah.
How do you think, or do you think that impacts clinical management, or how clinicians see their role or the person in front of them if every day they are sort of assessing resource utilisation?
So it does it in various different ways. I'm just going to see if I can get down to the rehab complexity scale. So it does it in different ways. So yes, we measure the nursing dependency scale, because that's looking at the impact on the nursing staff, who after all, we have to remember that people are providing the care 24 hours a day, 7 days a week, and they ultimately are, that resource is the limit on the number and complexity of patients we can bring in. That's the reason why we look at that, and for us it also depends on how many tracheostomies they've got. Again, the NPDS will pick up the number of tracheostomies, so we can really see that from nursing staff. But it also translates across to the medical and the therapy staff. So as well as that, as I mentioned, we score the rehab complexity scale every week. And I do that because I want to know not only the basic care and the nursing needs that are picked up also quantitatively by the NPDS, but also the therapy needs, the intensity of treatment, and the medical acuity of the ward. So we measure this every week, and I look at each of these before I go to that initial ward round, and that helps me to decide. Also, we know that, for example, if for 1 week we're particularly short of speech and language therapists, as I know we are at home this week, because I've had several emails about it, that will alter what we can bring in terms of new tracheostomies and so on. So we're constantly balancing that resource, and the rehab complexity scale, although it reflects complexity of rehabilitation, it's ultimately it's a measure of resources required. We can also use it to look at needs and gets. So actually we record it routinely for UK in terms of what somebody's getting, but we've done some smaller studies where we've looked at, this is what they get, but this is what they need, this is what we'd like to be providing them. And again, we can use that. And there's another dependency tool, which is the therapy dependency tool, which, like the nursing dependency tool, translates these items, which are ordinal items, into actual hours of nursing and therapy required. So using those tools together, I can look at a number of therapy hours I'm needing across the different disciplines. That's physio, OT, speech and language therapy, dietetics, psychology, social work, calculate the actual load in terms of the hours, and I can then equate that back to the actual staff we've got and see whether we're actually able to meet those hours required. So when you put all of these tools together, not one of them will do it. When you put them all together, you get a very good, clear view of the resources that you've got, that you need, and you've got a good case to argue for additional sort of resources if you need, which we've used on many occasions to increase our staff.
We've got a question from Stephen Foe as well, Lynne, and he'd like to know about the challenges in bringing this data to government.
Can I just check, Steve, does that mean the challenges we faced, or the overall challenges that might be faced? Oh, don't know if you can answer that. Maybe I'll talk about both of them.
That you faced, he's just put up.
That we faced, yes.
Yes.
Okay. So essentially, we were funded to do this work originally by the NIHR, and they're very much supported by the Department of Health to do it. So they realized they didn't have useful data about rehabilitation, either in terms of the resources, the patients, where they were, what they were getting, what they needed, how they were doing. And so we really responded to that accepted lack of knowledge within the Department of Health to provide the tools. And the challenge that we set out to meet was, as I say, to be able to provide the tools and validate the tools, to be able to capture that information day by day in the course of routine clinical practice, not just as a research project, but going forward. And so the focus was not just to do it once for 5 years, but to develop the tools, validate the tools, introduce them. And the way we managed to do that was by getting the Department of Health and NHS England, as it subsequently became, to buy into this. And the key bit was when the NHS England, which funds these services and commissions them, we managed to persuade them that once these tools were developed, they had to require the units to submit UK ROC data for every patient admitted as part of their routine care. So essentially, we had a situation where there was no data, no pay. And that, of course, is a strong motivating factor to get people to collect data. But it also meant, because it was mandated, that NHS England had to look at it. But they also found it very useful, and they did find and buy into the argument for cost efficiency. As a result of that, we've been able to expand our rehabilitation services, and just in the last year, we opened up another 32 beds across London for rapid access beds within rehabilitation beds within the trauma unit, recognizing the cost efficiency of that hyperacute early rehabilitation and the importance of doing that. I think in the challenge of how you do it, any part of health services research is not just about doing the research and providing the data and having the tools. It's also about really impacting in the policy, rolling up your sleeves and getting involved in policy. So I unashamedly gate crashed every policy development party, every working party that was trying to set up case mix, costing, HRGs, anything else like that. Whatever it was, I got in there, offered to chair the group and so on, or to help out. And so we managed to get these tools built into policy and have, therefore, NHS England, Department of Health, understanding what the tools meant, as well as the clinicians using them. So it's a kind of multi-pronged approach, and just, you know, being everywhere and being a general nuisance, as I call it.
Sounds like a lot of persistence. That's great. We've got a question from Dr. Jane Wu as well. I'll read it out. So rehab in Australia appears to be getting more complex year after year. Have you noticed an increase in rehab complexity score in the UK with time?
Absolutely, and indeed, not only have we noticed it, we've got the data to show it, because we've got progressive data year on year that shows exactly that thing in terms of the rehabilitation needs, the dependency of patients, the acuity of patients, and it's all getting more complex. Part of that is around the fact that we have got better acute services, so we rescue people in the early stages. Following accidents, trauma, people who have out of hospital cardiac arrest who have died at the scene previously, who now are resuscitated and brought into hospital, and then need ongoing care and rehabilitation. So as we're getting better at managing that acute care, keeping people alive in those early phases, we're then left with the legacy of that. Unfortunately, of course, some of those patients will do very well as a result of that early treatment, and they'll make a quicker and earlier recovery, but we'll also be left with that group of very profoundly disabled patients who survive often many years in a very dependent state. So it's not only in the rehab services, it's actually also needing resources for our ongoing care in the community and the specialist nursing homes to provide for people who need that lifelong care.
And Jane's just sort of extended on that. I think you started to go here anyway with your answer, Lynne, but she said, is the rehab complexity score, if it's getting higher over time, have you been able to use the data to ask for more staff? And I suppose, you know, has it led to some practical improvements for your services?
Absolutely. I mean, I've used it to increase the staffing on my unit. I think when we started off, we had something like 60 whole time equivalents. I now have over 105 whole time equivalents, and actually I think it probably has increased since then as well. So we've actually been able to make the case for more nurses on the ward. When we increased we were able to show the increase in complexity as we took on more patients, for example, with prolonged disorders of consciousness, with tracheostomies and people requiring ventilators. And so when we were able to not just say, look, we've got so many trachea patients, so many patients in PD, we were actually able to give them direct information on the nursing and therapy hours required for each of those patients, and therefore the total nursing and therapy requirement that we needed. And we're not only doing that in my unit, we provide data nationally for all of the units. They send us on their profile of the therapy, medical and nursing staff, and they send us our North Park dependency scales and the rehab complexity scales, and we have national standards for those, and that allows us to identify whether they're functioning as a level 1 or a level 2 service, whether the complexity of their profile is such that they actually need upgrading in that hierarchy, because essentially a level 1 service has, by definition, 85% of patients have category A level 1 needs, whereas a level 2 service is designed to have a bit of a mix, maybe fewer category A patients, maybe 30%, majority have level category B needs, but actually if we're showing through the complexity scale that they're and the other scores, including something called a patient categorization tool, that they've got a higher proportion of those patients with complex needs, then clearly they can move the service designation as well. So we see that, and we re-signpost patient units to those different levels as their complexity profile changes, and we'll be able to give them back their progressive change in complexity scores over the years, and also exactly how that reflects back into the total number of therapy and nursing staff hours needed per occupied bed. So it's been quite powerful for argument processes.
That's good to hear that you've had some really practical, tangible changes come out of that. We're getting a little bit of time left. Any other questions? I don't see any hands raised. No? Okay. I might just ask one more, Lynne, just zooming out. It might strike fear into the hearts of rehab doctors a little bit, but do you think that there is a place for rehab specialists having this perspective on rehabilitation, as in the value perspective, the economic perspective, and so on, and if there is there a place for this sort of understanding in training?
I think we live in an environment now where it's impossible to ignore the fact that the people who pay for health services, not just rehabilitation, but all health services, are conscious of cost, and they're conscious of value for money. I think there's no health service in the world that has all of the services that they need or would like to provide. And so they have to make some tough decisions about, where to spend that money that will give them extra value for their investment. And I think, we are very naive if we think we can just argue for rehabilitation or any other service on the basis that it provides improved quality of life for patients and makes people feel better. We can't even argue for, well, it makes them more independent. These days, we have to put figures on that. And we have to put figures on it, not only in terms of the traditional ordinal scales that show that there's been an improvement, but actually translate that into costs. Health economics is become part of our fact of life. So I think it's really important that people, all doctors, should start to have a handle on this and be reasonably savvy about that in their decision making. There are lots of tough decisions that we have to make on all sorts of grounds, and we're used to kind of making them on the basis there's scarcity of resources. There's not always that consciousness that you have to make decisions sometimes based on cost. But I'll often have a conversation in my ward round when my therapy team are, quite reasonably saying we want another extension for another couple of weeks because we want to achieve these goals, because that will help get this patient, home, or they'll help them be a bit more independent wherever they go. And we'd like to be able to do that because they can see that improvement would be possible to do. But actually, we then have to think, well, are we the right person to provide that? Could they get that more cheaply elsewhere? Is there what is the overall benefit if they're ending up going to a nursing home, which they may be anyway in the UK? What is the actual benefit going to be? And we don't like to think in those terms, in terms of cost, but we're going to have to learn to as physicians. We can't just hide in the clinical space. We've got to understand the pressures really that the people who purchase services are under, because that long-standing doctor's dilemma. I don't know if people remember the George Bernard Shaw play, The Doctor's Dilemma, when there's one dose of anti-TB treatment, and do they give it to the poor physician or the talented but scurrilous artist? That was a moral dilemma. But our commissioners are having to make these decisions based on cost the entire time. And so we have to help them. We have to find ways of doing that, and we have to understand, and we have to have that dialogue with them. So absolutely should be part of everybody's basic training, not just in rehabilitation, but across the board.
Thanks, Lynne. If we have no other questions, I might conclude the session there. So, Amanda, was there anything else to add at your end?
Do you want to say anything about the project?
Yeah, I guess some of you might be aware that I'm working alongside Lynne and Tash to look at an extension of the work that Lynne's presented here that was previously led by Tash at Caulfield, looking at the cost effectiveness in brain injury rehab. So we are commencing a study hopefully towards the end of the year with sites across New South Wales, Queensland, Victoria and South Australia, and we'll be using a lot of these tools to evaluate the cost efficiency of rehab across general rehab cohorts, and looking at what we'll be collecting the RCS as well as the FIM-FAM as well, to just look at a broader cohort of people and more relevance to Australia as well. So you can watch this space. We'll hopefully be presenting the outcomes of that work in the coming year or two as we get that published. So.
And I'd probably add to that it's really important that we get that piece of research done, because I think, you know, being able to use and demonstrate in a robust way that what we've shown in Tash's unit is applicable across a wider selection of services is really important to underpin that. But equally, you know, the tools are available. All of our tools, the rehab complexity scale, the North Park dependency scales, the FAM items, they're free to use. They're not restricted by license. They don't require accreditation. The software is available on the through the internet or through contacting us, so long as it doesn't impede on people collecting the data, which is really important for the research. We're very happy for people to ask us about the tools, require them, try using them in their service, because I think the next step is really to try and say, okay, so the principle works, but I'm sure this model needs tweaking and adapting and developing for the Australian context. I don't think necessarily just transplanting it. We've done some adaptation, but, you know, to have it grow in a different health culture, I'm sure there are other things that need to be done. And so we're very much up for that. And as I say, the software works on Excel. Anybody who's got Excel on PC can use it. It's not restricted, but it does give you that added value and that opportunity to use those timetables, for example, to start planning for the NDIS, you know, care plans when patients are discharged. It's a generic score. It's not got all of the answers, but it's a framework that people may be able to use. So there's lots of stuff. It's there. It's free to share. Don't let it interfere with the research, but very happy for anybody to contact us. We can make sure that people have the contact for the UK ROC team. I'm happy to have people follow up and answer any questions. So and help and share the tools.
And Gaj, I might send an email to yourself and Alex probably by the end of the week with a bit of summary and some links and things that you could just share generically if people are interested. Probably end of the week next week, I can send that for you to circulate.
Terrific, thanks. I think people would like that. And yeah, so this video will be made available as well afterwards. Yeah, thank you so much, Lynne. That was a really terrific, thought-provoking presentation, and I think it's also always great for us to see rehabilitation in an international context as well, because it's easy to just sort of look in your own backyard, but everyone's got the same problems they're dealing with apparently all over the world. So it's good to see and see that. Okay, thank you, everybody. I hope you enjoyed this session, and we'll get those additional contact details out to you in coming weeks. Thank you very much.
Thank you.
Thank you.